Welcome to the introductory training entitled Enhanced Care Management, ECM 101. This 50-minute training is designed as a supplement to the Policy to Practice training CalAIM 101, although it can also be used as a standalone training. ECM 101 provides an overview of the Medi-Cal benefit of enhanced care management, which was launched in 2022. The goal of this training is for ECM workforce members, especially lead care managers and their supervisors, to have a better understanding of their roles, responsibilities, and the impact they can make in improving the lives of the most vulnerable Medi-Cal members. Today, our training objectives will be 1. To describe the start-to-finish process of ECM service delivery. 2. To illustrate the pivotal role of the lead care manager in the whole-person care approach. And 3. To review the 7 ECM core service components and how they function to strengthen care. Our covered topics today will include CalAIM and Enhanced Care Management, ECM Populations of Focus, ECM Providers, Identification, Referral, and Authorization of Members, the Lead Care Manager, Data Sharing, 7 core ECM service components, Discontinuation of ECM, and Takeaways. Enhanced Care Management, or ECM, is a critical component of California Advancing and Innovating Medi-Cal, CalAIM. CalAIM is a massive undertaking, aiming to bring about significant, multi-layered change and expansion to California's Medicaid program. Starting in January of 2022, for certain populations of focus, Enhanced Care Management became a new statewide benefit for eligible members of Medi-Cal managed care plans. ECM is a whole-person, interdisciplinary approach to care that addresses the clinical and non-clinical needs of members with the most complex medical and social needs. The ECM benefit is in part a response to the reality that over half of Medi-Cal spending applies to just 5% of Medi-Cal enrollees, as well as a response to California's escalating homelessness crisis. The guiding vision for this coordination is that the most vulnerable Californians will have their basic needs met and live in their communities with health, dignity, purpose, and a sense of belonging. The overarching goals of enhanced care management are improving care coordination, integrating services, facilitating community resources, addressing the social drivers of health, improving health outcomes, and decreasing inappropriate utilization and duplication of services. The World Health Organization defines the social drivers of health, also known as the social determinants of health, as the non-medical factors that influence health outcomes. These drivers are grouped into 5 categories: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Enhanced care management is designed to bridge the traditional healthcare system with social services, providing a whole-person approach to care. Enhanced Care Management is an outgrowth of the Whole-Person Care Pilots, launched in 2016, and the Health Homes program, launched in 2018. Both of these initiatives offered community-based, complex care management to high-needs enrollees, but on a limited basis across the state. Starting in 2022, when the rollout of ECM as a statewide benefit began, participants of the Health Homes program and Whole-Person Care Pilots were automatically enrolled in Enhanced Care Management. Findings from an evaluation of the Health Homes program indicated improvements in emergency department and hospitalization utilization, access to needed outpatient services, screening for depression and follow-up, and overall estimated Medi-Cal payments. Of the 25 whole-person care WCP pilots, relationship building and silo busting, both internally within government systems and externally within community-based partners, were noted as significant successes. Additionally, these pilots provided the opportunity to address the needs of Medi-Cal beneficiaries who have been historically marginalized and/or are experiencing health disparities. The rollout of ECM across the entire Medi-Cal population occurred in phases across 9 populations of focus, or POFs. The rollout began in January of 2022 and ended in January of 2024 when the last 2 POFs, Birth Equity and Individuals Transitioning from Incarceration, were launched. The goal is that all Medi-Cal managed care members who qualify for enhanced care management will receive it. Medi-Cal managed care plan members must meet very specific eligibility criteria to qualify for enhanced care management. Some eligibility categories are limited to adults, defined as an individual 21 years of age and older, and some are limited to youth, defined as an individual under the age of 21. Youth who have aged out of foster care may qualify for ECM up to the age of 26. As an example of the nuances of eligibility criteria, the population of focus individuals experiencing homelessness has 2 distinct sets of criteria. One set applies to adults without dependent children, youth. To be eligible for ECM, the adult must meet at least one of 6 definitions of homelessness and have at least one complex physical, behavioral, or developmental need with the inability to successfully self-manage. The other set of criteria for this POF applies to homeless families or unaccompanied children, youth. Eligibility is determined by meeting one of 2 definitions of homelessness. Children, youth, and families do not need to meet the additional complex physical, behavioral, or developmental need criteria that adults must meet. Managed care plans must use DHCS eligibility criteria to evaluate members and may not impose additional eligibility requirements for authorization of ECM. The 9 populations of focus for enhanced care management are: all ages, homeless, includes adults with dependent children, youth living with them, and homeless families or unaccompanied children, youth experiencing homelessness. At risk for avoidable hospitalization or emergency department ED utilization, formerly high utilizers. Serious mental health and/or substance use disorder SUD needs. Transitioning from incarceration. Birth equity. Adults only. Living in the community and at risk of long-term care institutionalization. Residing in a nursing facility and transitioning to the community. Children and youth only. Enrolled in a California Children's Services Program for children with certain diseases or health problems, or CCS Whole Child Model with additional needs beyond the CCS condition. Involved in child welfare. All populations of focus receive 7 core services under enhanced care management: outreach and engagement, comprehensive assessment and care management plan, enhanced coordination of care, comprehensive transitional care, health promotion, member and family supports, coordination of and referral to community and social support services. These components will be covered in more depth later in our training. Enhanced care management is expected to be delivered primarily through in-person contact. It is important to emphasize that ECM is not telephonic case management. This in-person contact should occur where members and their family members, guardians, authorized representatives, caregivers, and authorized support persons live, seek care, or prefer to access services in their local community. Examples of such locations include on the street, in a shelter, at home, or in a doctor's office. The Department of Healthcare Services emphasizes it is critical for ECM providers to establish strong relationships with these members and their parent, caregiver, or guardian, if applicable, and this will occur most effectively through in-person interactions in locations most convenient for the member. Other forms of contact, such as mail, email, texts, telephone calls, and secured teleconferencing, may be used when in-person contact is not available or the member prefers an alternative. DHCS defines ECM providers as community-based entities with experience and expertise providing intensive, in-person care management services to individuals in one or more of the populations of focus for ECM. Managed care plans are responsible for maintaining a network of ECM providers who have an existing footprint in the communities they serve and who are collectively able to meet the complex and extensive needs of the 9 populations of focus. While DHCS initially approved some MCPs to use their own staff as ECM providers, these exceptions ended in June 2024. Enhanced care management is more than simply referring the member to needed medical or non-medical services, as DHCS notes that ECM providers will generally hold the primary relationship with members receiving ECM. ECM providers work in a persistent and high-touch manner to coordinate care across the member's needs. A key requirement for ECM providers is that they have the capacity to provide culturally appropriate and timely in-person care management activities, including accompanying members to critical appointments when necessary. Additionally, ECM providers must have partnerships in place with area hospitals, primary care practices, behavioral health providers, community supports providers, and other organizations to effectively coordinate care for each assigned member. The ECM provider network is vast, diverse, and growing, spanning the nonprofit and government sectors, including, but not limited to, the following entity types: federally qualified health centers, skilled nursing facilities, counties, community mental health centers, substance use disorder treatment providers, primary care providers, local health departments, community-based organizations, hospitals or hospital-based physician groups or clinics, rural health clinics, Indian Health Service programs, California Children's Services providers, school-based health centers, regional centers, and First 5 county commissions. Managed care plans are required to list contracted ECM providers in their provider directory under the category of Other Services Providers. Network directories must also list the populations of focus served by each provider. ECM providers should verify their inclusion in plan directories and, if left out, follow up with the MCP to ensure compliance with DHCS policy. Managed care plans, MCPs, are now tasked with extensive responsibilities in implementing the enhanced care benefit to eligible members. For example, the Department of Healthcare Services, DHCS, requires that MCPs review a wide range of data across multiple data sources and information systems to identify members who may qualify for this benefit. This data includes, for example, utilization and claims data, such as emergency room visits and hospitalizations, to identify repeat users of these high-cost services. Adverse childhood experiences, or ACEs, screening results, as well as diagnoses that reflect social drivers of health. Cross-sector data related to the various populations of focus, such as foster care, housing, criminal justice, regional center, and social services data. DHCS clarifies, The primary mechanism for member identification should be referrals from the community. The community of potential referral sources includes, but is not limited to, members and their families, primary care physicians or PCPs, ECM and community supports providers, and community-based organizations or CBOs. Managed care plans are also expected to continuously build partnerships with non-traditional healthcare organizations such as homeless shelters and the community at large to strengthen the ECM referral network and referral process. DHCS has taken significant steps to streamline and standardize the ECM referral and authorization process. In August of 2024, DHCS announced the creation of Universal ECM Referral Standards. These standards aim to improve the consistency of information collected by MCPs to process an ECM referral, so that entities making referrals to multiple MCPs have a predictable common set of information they must send on each member referred to ECM. Starting January 1, 2025, all managed care plans must adopt these new requirements for initial ECM referrals, including updating their referral forms, public-facing web pages, member handbook, and overall procedures to comply with this high level of DHCS standardization. Key MCP compliance areas include electronic and form-based, for example PDF, referral pathways, standardized language about the referral process and eligibility criteria, specific data elements for Medi-Cal member information and referral source information, population of focus eligibility indicators for adults and children youth. Examples of required elements for Medi-Cal member information include the member's managed care plan, date of birth, and primary phone number. Examples of required elements for referral source information include the referring organization name, referring individual name, and referring individual relationship to member. Importantly, managed care plans may not impose additional requirements for reviewing a member's eligibility beyond what is included in the ECM referral standards. Additionally, the self-referral process is simplified for members and families, as a call or other communication to the MCP is adequate to initiate the referral. Consistent with Medi-Cal overarching principles, managed care plans review each referral for enhanced care management on an individualized basis and in accordance with the populations of focus eligibility criteria. The eligibility criteria are not flexible and must be strictly adhered to by the managed care plan. MCPs must develop policies and procedures to ensure that this authorization process is non-discriminatory and does not disrupt the care the member is currently receiving. As per their contract with the DHCS, managed care plans must make an authorization decision no later than 5 business days for routine authorizations and within 72 hours for expedited requests. For all members authorized to receive ECM, the initial authorization period will be 12 months and the reauthorization period will be 6 months. DHCS encourages ECM providers to cite back this policy to the MCP if a routine determination is not made within the 5 days. If the MCP denies ECM for the member, this denial must be made formally by a notice of action and must include the reason for the denial as well as the member's right to appeal. Alongside its August 2024 release of Universal Referral Standards, DHCS also updated its ECM Presumptive Authorization Policy. These changes reflect DHCS's continuing efforts to not only ease the administrative burden of the referral and authorization process, but also allow certain ECM providers to more rapidly initiate ECM services and engage members in the care they need. The Presumptive Authorization Policy allows certain ECM providers to directly authorize ECM for a time frame of 30 calendar days and to be paid by the member's managed care plan for those services. This policy applies only to the initial ECM authorization for the member, not subsequent renewals and reauthorizations. For each of the 9 populations of focus, DHCS designates certain ECM providers who are already contracted with MCPs as eligible for presumptive authorization requirements. For example, OB/GYN practices, as well as midwifery practices, are eligible for presumptive authorization for the birth equity population of focus. As another example, primary care provider practices are eligible for the adults and children at risk for avoidable hospital or emergency department population of focus. As of January 1, 2025, managed care plans are required to implement these presumptive authorization arrangements with eligible ECM providers. MCPs must also train these providers on how to access a member's existing ECM authorization status to avoid potential duplication of services. ECM providers should confirm if they meet DHCS eligibility criteria for presumptive authorization, and eligible providers should familiarize themselves with the DHCS policy. Once approved for enhanced care management, the managed care plan assigns the member to one single ECM provider who can best meet the member's unique needs. This assignment is based on a variety of factors, including, but not limited to, the member's preferences, the populations of focus criteria that the member meets, the type of services currently being received, and the composition of the ECM provider network in the member's community. The Department of Healthcare Services, DHCS, asserts the MCP should prioritize assignment of the member to a provider who is already known and trusted by the member. For example, if the MCP is aware that the member has a preference for a specific ECM provider, the MCP honors that preference unless there are extenuating circumstances. In the event the member meets more than one population of focus category, the member must be assigned to a provider who is able to meet these multiple needs. This assignment is communicated to the ECM provider within 10 business days of authorization. Members have the right to change ECM providers at any time, and MCPs must generally honor this request within 30 days. Upon referral to an ECM provider, the member must be assigned to a lead care manager, or LCM. The lead care manager is an employee or contractor of the ECM provider and serves as the primary point of contact for the member and authorized family and other supports. This lead care manager is responsible for engaging with the multidisciplinary care team to identify gaps in the member's care and ensure appropriate input is obtained to effectively coordinate all primary, behavioral, developmental, oral health, long-term support services, community supports, and other services that address social drivers of health, regardless of setting. Some managed care plans establish specific roles and functions for the multidisciplinary care team. As one example, LA Care utilizes a care team model that includes an ECM director, who assumes overall responsibility for the organization's ECM teams. This model also incorporates a clinical consultant, who is a licensed professional and provides clinical oversight of ECM service delivery. Consistent with the ECM philosophy, the lead interacts with members in person and at convenient locations. The LCM ensures that care is integrated yet not duplicative, and this role serves as the primary coordinator in the event the member has other case managers. At this time, DHCS is not setting any requirements for the minimum or maximum number of members who can be served by each lead care manager. The lead care manager plays the pivotal role in the success of the enhanced care management benefit. As the lead works directly with the most vulnerable Medi-Cal members, they are in a very unique position to make a difference in the lives of the members they serve, especially as they work with communities that have historically been underserved in the Medi-Cal program. The Department of Healthcare Services does not require that the lead care manager be a licensed clinical staff person, such as an RN or LCSW, and delegates the process of vetting qualifications and experience to each managed care plan. That being said, certain personal characteristics and skills are essential for this role. One ECM provider reflects, when we hire, especially when we focus on hiring people with lived experiences, we're really looking for people to have an ability to connect with and build trusting relationships with the client. While the lead care manager communicates with various professionals, these activities will only be successful if the lead keeps the members at the center of this process. This centering includes getting to know the strengths, needs, preferences, and culture of each member so they can serve as an advocate across all systems of care. DHCS notes, the ECM lead care manager must know every component of the member's needs and services and ensure they are coordinated. One of the most critical roles of the lead care manager is to serve as this holder of the big picture for each assigned member. This responsibility means having a bird's eye view of all the services, both clinical and non-clinical, being utilized or needed by the member. The bird's eye view should consider, for example, the following services and needs: clinical, primary health; behavioral health, which includes mental health and substance use disorders; developmental health; oral health; palliative care; and long-term services and supports. Non-clinical or social needs are housing, home modifications, nutrition, personal care and homemaker services, caregiver respite, and other social supports. In order for the lead care manager to develop this bird's eye view, there must be timely, streamlined, and meaningful sharing of information between the ECM provider and the managed care plan. As such, the DHCS establishes parameters for member-level information sharing. DHCS initially outlined 4 unique data file types, which include specific data elements, suggested file formats such as Excel and its transmission frequency, and secure transmission methods. The file types are: 1. MCP Member Information File. This file includes demographic, clinical, and utilization information about the member. For example, the diagnosis of chronic conditions the member may have, including but not limited to asthma, serious mental illness, SMI, substance use disorder, SUD, dementia, traumatic brain injury, and diabetes. This dataset also includes the member's ER visits and inpatient hospitalizations over the past 6 months, as well as their medications and primary care physician information. Number 2. ECM Provider Return Transmission File. This file includes information for the managed care plan about the ECM provider organization and the assigned lead care manager. It also includes the ECM status of the member, which is designated in one of 5 categories: pending outreach, currently in outreach, enrolled, declined, or excluded, as well as a reason for and recommendation for a discontinuation date if applicable. Number 3. ECM Provider Initial Outreach Tracker File. ECM providers need to report on their attempts to engage MCP-referred members. An outreach attempt is defined as an in-person or telephonic electronic attempt to connect with an individual member for the purpose of enrolling the member in the ECM benefit. This tracker file includes the dates of the outreach attempts as well as the method. And 4. Potential ECM Member Referral File. This file is the means for ECM providers to refer potential ECM recipients to the MCP for consideration. As of January 1, 2025, this file will be eliminated and replaced by the ECM Universal Referral Standards. Outreach and engagement is the first phase and one of the 7 core components of enhanced care management. It begins promptly once a member has been authorized to receive ECM and matched to an appropriate ECM provider. Outreach can also begin prior to formal authorization, assuming the provider has a presumptive authorization arrangement in place with the managed care plan. As part of their DHCS-approved model of care, Each managed care plan must establish the number of required outreach attempts for ECM providers. Managed care plans must reimburse ECM providers for their outreach efforts, even when the member does not end up enrolling in ECM. DHCS is committed to ensuring that the majority of ECM referrals originate from community-based sources, and that ECM is provided by organizations who know members best. This allows providers to leverage their existing knowledge of and relationship with the member for a successful outreach and engagement phase, instead of resorting to a cold call approach. In terms of the lessons learned from the home health program, there was widespread agreement that for the HHP-eligible population, telephonic outreach was much less successful than in-person communication and engagement. Other strategies for an ECM provider's success were identified as using persistent outreach and the development of a clear follow-up plan upon initial member contact. The follow-up plan should include a significant stated need of the member. For example, if a member requests an appointment with an authorized specialist, the lead care manager should make that appointment, communicate it to the member, ensure transportation, and follow up with the member afterwards. This type of early win builds trust with the member and demonstrates the lead does care and will deliver on a promise. A critical part of outreach and engagement includes introducing the member to ECM. As ECM targets historically underserved individuals, taking this time and care to explain to members what to expect helps to build trust and transparency and promote self-determination. Key communication points include: ECM provides additional support to help people who struggle with serious health issues as well as other difficulties like homelessness. This additional support is free of charge. It includes helping members to find doctors and make appointments, understand prescription drugs, set up transportation to doctor visits, get follow-up after a hospitalization, apply for community programs and social services. Each person receiving ECM has a dedicated lead care manager who serves as the primary point of contact for the member and their family and supports. ECM services are individualized and are centered around the unique needs, strengths, and preferences of the member. ECM is voluntary and can be declined at any time without impacting other services members receive under Medi-Cal. Given the comprehensive nature of this support, members may need reassurance that ECM is available at no cost to those who qualify. The Comprehensive Assessment and Care Management Plan is the second core component of enhanced care management. This two-phased process serves as a roadmap for the coordination of the member's care across the spectrum of all clinical and non-clinical services. Importantly, DHCS has not issued standardized forms or formats for assessments and care plans. However, it has stipulated certain required elements that a managed care plan must address in their unique model of care. These elements include, for example, how an ECM provider is to evaluate a member's medical needs, identify gaps in care, and coordinate support services. In general, this assessment and care planning process is rooted in collaboration with the member and their authorized parent, caregiver, guardian, other family members, and other authorized support persons. It includes individually addressing each member's unique strengths, needs, risks, preferences, and goals, as well as including clinical input from the member's multidisciplinary team. DHCS does not require an annual assessment for members. Rather, managed care plans have the responsibility to develop clinically appropriate reassessment standards that minimize the administrative burden on ECM providers. In general, completion of the comprehensive assessment considers the member's physical, mental health, and substance use disorder needs, as well as their social support needs. The assessment process also includes specific questions to determine if the member needs long-term services and supports, or LTSS, to maintain community living. LTSS questions include, for example, if the member needs support with activities of daily living, such as taking a bath or shower, eating or getting dressed, or if the member needs support to live safely in their homes, such as having adequate lighting, heating, and hot water. Another key assessment consideration is the member's adverse childhood experiences, or ACEs, which the Centers for Disease Control defines as potentially traumatic events that occur in childhood 0 to 17 years. In a landmark study conducted by the CDC and Kaiser Permanente during the 1990s, the findings showed that the more ACEs a person has, the greater risk for negative outcomes in the areas of mental health, maternal health, infectious and chronic disease, and alcohol and drug abuse. As part of California's ACEs Aware initiative, clinicians who are trained in using the standard screening tools are eligible for Medi-Cal reimbursement for this optional service. If available, the results of the member's ACEs screening, particularly the level of risk defined as low, intermediate, high, or unknown, can be used to determine appropriate response and follow-up on the care plan. After the completion of the comprehensive assessment, the ECM Care Management Plan is created in collaboration with the member. The ECM Care Management Plan is considered to be a living, breathing document that is updated as changes occur. It must be reviewed, maintained, and updated under appropriate clinical oversight. ECM providers must use a case management or other record-keeping system to document member goals and goal attainment status, develop and assign care team tasks, define and support member care coordination and care management needs, gather information from other sources to identify member needs and support care team coordination and communication, and support notifications regarding member health status and transitions in care, such as discharges from a hospital or LTC facility and housing status. This system must ultimately support the management and maintenance of a member care plan that can be shared with other providers and organizations involved in the member's care. Enhanced coordination of care is the actual living out of the care management plan. The hallmark of this activity is communication among the multidisciplinary team and with the member, with the goal of monitoring and improving the member's whole health status and effective use of available resources. The lead care manager makes sure that the member is linked to a primary care physician and is taking part in primary care services. The lead is also responsible for coordination of medication review and/or reconciliation. Other activities of the lead care manager include, but are not limited to, scheduling appointments, providing appointment reminders, coordinating transportation, accompanying the member to important appointments, and problem-solving challenges with integration of care as they arise. The ECM component of comprehensive transitional care involves the implementation and updating as needed of a clear and thoughtful plan as to what the member needs to live successfully in the community and avoid readmission. This process is especially important as the member transitions from one level of care to another. For example, a discharge from a hospital to a home or community-based setting. The ECM lead care manager plays a central role in care transitions. Their responsibilities include communication and coordination with discharging facility staff to create one streamlined discharge plan that is implemented across all of the members' multidisciplinary care team. The DHCS emphasizes that transition care includes supporting members' transition from discharge planning until they have been successfully connected to all needed services and supports. Care also includes assisting the member in understanding what steps they need to take during this transition, such as managing their medications and making use of available resources to live optimally in the community. Another of the ECM core components, health promotion, encourages and supports members receiving ECM to make lifestyle choices based on healthy behavior with the goal of motivating members to successfully monitor and manage their health. Health promotion services are available to all Medi-Cal members as part of the Basic Population Health Management Initiative. This component includes helping members to grow and strengthen their natural supports, including family, friends, and other social connections that encourage members to make healthy choices. It also works with the member to become more skilled at identifying and accessing needed resources. Health promotion also includes connecting the member to programs such as smoking cessation, self-help recovery, and support for chronic conditions. Another lesson learned from the Health Homes program is the value of motivational interviewing in this change process. Motivational interviewing is defined as a collaborative, goal-oriented style of communication with a particular attention to the language of change. It is a person-centered, evidence-based approach rooted in 4 core principles of partnership, acceptance, evocation of solutions, and compassion. Motivational interviewing is a critical skill for lead care managers, as they are uniquely positioned to use this technique not only for health promotion, but across all ECM components. The ECM component of member and family supports includes activities that ensure the ECM member and family or other authorized support persons are knowledgeable about the member's conditions. The overall goal is to improve the member's adherence to treatment, including their medication management. A key responsibility of the lead care manager is to work with the member to identify these support persons, document them, and obtain valid authorization from the member to share information about the member's treatment. The care management plan is part of the information that is shared so that each support person, and not just the professionals, are all on the same page on how to best help the member. The final core component of enhanced care management involves determining appropriate services to meet the needs of members receiving ECM to ensure that any present or emerging social factors can be identified and properly addressed. All managed care plans are encouraged to offer as many of the following 14 Medi-Cal approved community supports as possible: housing transition navigation services, housing deposits, housing tenancy and sustaining services, short-term post-hospitalization housing, recuperative care or medical respite, day habilitation programs, caregiver respite services, nursing facility transition diversion to assisted living facilities, community transition services nursing facility transition to a home, personal care and homemaker services, environmental accessibility adaptations or home modifications, medically supportive food, meals, medically tailored meals, sobering centers, and asthma remediation. Community supports can make a profound impact on the lives of Medi-Cal members. As such, community support providers should confirm their listing in contracted managed care plan directories, and lead care managers should be familiar with local resources. In the event the member's managed care plan does not offer the community supports that a member needs, the lead care manager must identify alternative resources in the community to meet these social needs. Part of this responsibility includes closing the loop between referral and the rendering of service. Enhanced care management may be discontinued when any of the following circumstances are met. The member has met all care plan goals. The member is ready to transition to a lower level of care. The member no longer wishes to receive ECM or is unresponsive or unwilling to engage. This can include instances when a member's behavior or environment is unsafe for the ECM provider, or the ECM provider has not been able to connect with the member and/or parent, caregiver, guardian after multiple attempts. The managed care plan decides if ECM should be discontinued for a member, and if so, communicates the decision to the member via a written notice of action. MCPs must also have procedures in place to describe how members will be transitioned from ECM to lower levels of care management. Enhanced care management is a critical component of CalAIM, serving the highest needs, most vulnerable individuals. ECM is also an opportunity to serve persons who have been historically marginalized and to ultimately further an equitable health system in which every person has the fair and just opportunity to attain their highest level of health. This Medi-Cal benefit is in full implementation across the state of California. It represents a significant shift in healthcare, making the coordination and integration of care among a wide array of organizations and professionals the most vital, distinct function. The importance of the lead care manager in this shift is critical, as this role keeps the member at the center of this change. The Department of Healthcare Services emphasizes that the CalAIM transformation requires the investment and sustained commitment of a broad network of health partners, including plans, providers, and community-based organizations. Given the magnitude of this endeavor, we are all engaged in a collective learning process that will evolve over time. As such, ECM providers should take the long view in addressing challenges that will naturally arise with any major change undertaking. This long view is the vision of longer, healthier, and happier lives for people with Medi-Cal. This slide includes key resources and primary references. For a list of all references, including page citations for any quotes, please see the training transcript. Questions about this training can be directed to CalAIM@dhcs.ca.gov.